Okay, let's start with pneumonia. Okay, what do we have here? So we have, first thing we have is lobar pneumonia, right? So just gotta know these organisms, okay, very well. Organisms, somehow gotta memorize them. So in lobar pneumonia, meaning one lobe is just out, that is caused by most commonly strep pneumonia. That's easy, right? Strep pneumonia, lobar pneumonia, easy. Legionella, Klebsiella. So strep pneumonia, Legionella, Klebsiella, right? Uh, what is the characteristic of a lobar pneumonia? It's intra-alveolar exudate. Remember what we talked about exudate? We said that's just inflammation, um, and everything would be increased in the light criteria, and that would cause consolidation, which is picture A, may involve entire lobe or the whole lung. So full one lobe or the whole lung. Bronchopneumonia. Again, you have strep pneumonia, Staph aureus, H. influenza, and Klebsiella. So this two just come from top. Two new are here, Staph aureus and H. influenza. It's also acute inflammation infiltrates from the bronchioles into adjacent alveoli with patchy distribution involving more than one lobe. Patchy distribution within the bronchioles, it's called bronchopneumonia. Now, interstitial one, which is atypical pneumonia, this is caused by Mycoplasma, Chlamydiophila pneumonia, Chlamydophila pistacea, Legionella coxiella burnetii, viruses or so see we have viruses here now. So one of the things to know it is most commonly these two are caused by bacteria, and this guy is caused by bacteria plus viruses. So viruses are RSV, CMV, influenza, and adenovirus. It is diffuse patchy inflammation localized to interstitial areas at the alveolar walls. Chest X-ray would show bilateral multifocal opacities. Look at picture B. So you have bilateral multifocal opacities will be seen. Generally follows more indolent course, which is walking pneumonia. Meaning, what is walking pneumonia? The patient will be asymptomatic. But when you do the chest X-ray, you will see all of this, which is a multifocal bilateral opacities. And the person is pretty fine. He's like, I have pneumonia. Wow. So it's atypical form, meaning it's atypical. Pneumonia doesn't present with atypical because this patient is not going to have fever or anything else. Okay. Then you have this cryptogenic pneumonia. What is cryptogenic pneumonia? Well, cryptogenic organizing pneumonia is unknown etiology, negative sputum and blood cultures, often responds to glucocorticoids but not to antibiotics. Okay, formerly called bronchiolitis obliterans, organizing pneumonia, BOOP, non-infectious pneumonia characterized by inflammation of bronchioles and surrounding structures. So it is not due to any bacteria, virus, or any infectious etiology. So what is it? Why do we have this then in the first place? Why would we have inflammation? So it is associated with chronic transplant rejection. Okay. And then what else you have is the last one, which is aspiration pneumonia. Aspirate, you already know what aspiration is. Aspiration of the oropharyngeal or the gastric contents causing pulmonary infection. Risk factors are altered mental status, which is decreased cough reflex or glottic closure, dysphagia, neurological disorders, stroke, invasive tube, nasogastric tube. Basically anything. If you somehow, if you are going to aspirate, meaning fluid is going to go from your esophagus to your trachea and going into the lungs, or you somehow it doesn't go to esophagus when you're taking something in and it goes into the trachea, it is aspiration, and that aspiration pneumonia can cause that aspiration can lead to pneumonia, and these are all the risk factors, meaning all of these are the factors that can lead to that. So it's going to present days after. That's important. It's going to present. It's not so you aspirate something, it's not going to present right away. It's going to present days after aspiration event, independent lung segment. And we did talk about how in which position you are. If you aspirate, where thing would go in the lungs, right? So that's again back in the anatomy portion. More common is the right lower lung lobe. If sitting up, so if you're sitting up, you are looking at right lower lung. If you and right upper lung if lying down. So if you're lying down, right upper lobe. Due to the bronchial anatomy, can progress to abscess. So whatever the particle that went down, it can lead to abscess, inflammation, abscess, right? The next is aspiration chemical pneumonitis. So this is basically, you aspirated a chemical causing pneumonitis, inflammation. So it presents with hours after. So this is going to present hours after aspiration event due to gastric acid mediated inflammation, presents with infiltrates in the lower lobe, resolved with supportive treatment. So what is the difference between aspiration of pneumonia versus aspiration of a chemical substance? Is about the presentation, one thing, and the second thing, where are they going? Aspiration pneumonia is going to present with days after the aspiration, while if you have a chemical you aspirate on, it's going to present right away, hours after the aspiration event. Okay, and it's going to be more in the lower lobes. Okay, let's look at some more important points. Let me erase this. Okay, what are the clinical features? Somebody comes in with pneumonia, any type, except atypical. What are the features, clinical features, how they're going to present with? So they will be having fever, chills. Fever, chills, what else? Fever, chills, productive cough, dyspnea. And in the productive cough, they can have two things. Could have yellow-green pus, which is called yellow-green pus, sort of a cough, or rusty sputum, which is a bloody cough. Okay, and they can also have pleuritic chest pain. And what else? And again, dullness to percussion, bronchial breath sounds, and egophony will be seen, and that also is back in the table. An increase in WBCs for sure. Legionella will classically be presented by it is transmitted via water source visualized by silver stain. So some water source, silver stain. So that's specific for Legionella. For Klebsiella, they're going to have specifically gelatinous sputum. Which can lead to often, or you can say in other words, current jelly sputum. And often it can lead to abscess formation. Okay, and they sometimes ask you, what sort of a cells are you going to see in this exudate? So you do see, because it's an acute inflammation, right? It's an acute inflammation. So in acute inflammation, you always have neutrophils. Or what are the complications of this all or of these pneumonias? So you can go into sepsis. That's one complication. You can go into again, sepsis, abscess formation, respiratory failure, pleural effusion, or eventually can go into ARDS. Okay, so yeah, this is all about here. One important thing here is in aspiration pneumonia, the organisms from the oropharynx that can cause is Bacteroides, Fusobacterium, and these are all anaerobes, anaerobic bacteria from the oropharynx that go into the lung and causes the aspiration pneumonia. So Fusobacterium and Peptostreptococcus. Okay, so let's just recall the whole thing and move it on to the next one. So let's recall, let's start this. Okay, here what we have. Okay, we have a lobar pneumonia. Simple, it's an intra-alveolar exudate, leads to consolidation of the entire lobe or the whole lung. Bronchopneumonia, it's an acute inflammation causing the infiltrate from bronchioles. And it can involve more than one lobe. Interstitial atypical, it's a diffuse patchy inflammation, and it's going to look like bilateral multifocal opacities, and with more indolent course of walking pneumonia. What is cryptogenic? It is associated with, again, chronic transplant rejection, and it is non-infectious, meaning you're not going to see any infection. If you don't have an infection, you still have pneumonia, you think about cryptogenic pneumonia. That can be fixed via glucocorticoids, not the steroids, and not the antibiotics. Aspiration, it's if you aspirate oropharyngeal or gastric contents, it's going to present in days, but if you aspirate on chemical, it's going to present in hours. Again, pneumonia. And that's all for pneumonias. Now let's look at the natural history of lobar pneumonia. So as you know, there are some stages of this. So you have a congestion, then you will have red hepatization, gray hepatization, resolution. In the congestion state, the day it starts, the pneumonia starts is the 1 to 2 days, right? So finding is, this is congestion, so let's look at the finding. You have a red-purple partial consolidation of the parenchyma and exudate with mostly bacteria here, and you can see the red purple partial consolidation. And if you look here, you have the bacterias, and on top of it you have the exudate going into these capillaries and alveoli. So coming out of the capillaries into the alveoli. And in red hepatization, the next stage is that red-brown consolidation exudate. There is going to be exudate with fibrin, bacteria, RBC, WBC. So red hepatization, it is basically you have more now things going into the alveoli. You would have bacteria, RBCs, WBCs. So RBC, fibrin, you can see this WBC. So all the inflammatory cells are in red hepatization. Now gray hepatization is uniformly gray exudate full of WBCs, lysed RBCs. So you still have WBCs, but you have lysed RBCs and fibrin. Okay, because of that lysed RBCs, you don't see the red color. You call it gray. Here you call it red because you have a full-blown RBCs going in there, causing a full red color. Same thing goes here. Exudate with all that exudate going in, starting to go in. That's the congestion. Red hepatization. It's all of that blood going into it, causing red hepatization. That blood, then when it gets lysed, it's going to form a gray hepatization. And then after that, the last one within 8+ days, meaning more than 1 week, we're looking at here. Enzymatic digestion of the exudate by macrophages. So there is enzymatic digestion of the exudate by the macrophage, right? And if you look, it's all clear, and you just have resolution. Okay, and also one more thing here. Let's add some things to it. Okay, in congestion, we have, first of all, because we have an active inflammation. So which cells are we gonna have in the first place? Neutrophils. Neutrophils are gonna release those cytokines that would increase the capillary permeability, and that protein-rich fluid is going to start getting into uh, the alveolar spaces, causing the next stage, right? Heavy red hepatization. And then what's going to happen in your red hepatization is all of this is going to start coming down into the alveoli, giving it a liver sort of a texture. That's why we call it hepatization. The red, I told you red already. That all protein-rich fluid um, forms into these fibrins, which you can see here. Fibrin strand, which on exudate formed by the neutrophil, erythrocyte, and fibrin. And gross examination will appear as a liver texture. That's what I call hepatization. A red, firm, airless lung looks like liver. And then in the gray hepatization, you have which cells are going to have. That's important. The WBCs here we're going to look at is you will have increase in more infiltration of those leukocytes, and neutrophils are going to be replaced. At this stage, neutrophils are replaced by macrophages. So it started with neutrophils going into macrophages, acute and chronic inflammation. They begin the repair process. So these guys are going to go and lyse RBCs, even everything else, and start the process of repair. What is repair eventually in resolution, right? If you recall, type 2 pneumocytes were the one with the stem cells, right? So they will start the repair process. Oops, give me 1 second. Okay, yeah. So type 2 pneumocytes are the stem cells, remember? So they will start the repair process. They will regenerate type 1 cells, and they will regenerate themselves. On top of they will regenerate that surfactant. And also, it's going to be done. The whole resolution is going to be done with the 3 weeks. So a lower pneumonia occurs, you have about 3 weeks till the resolution can occur. Okay, and that's pretty much what we have for all of this. So looking at the lung abscess. Lung abscess is localized collection of pus within parenchyma caused by the aspiration of oropharyngeal contents, especially in patients with predisposed to loss of consciousness, alcohol overuse, epilepsy, or bronchial obstruction, cancer. So all they're trying to say again, same thing, that if you aspirate, normal individual won't aspirate, right? You got to have some problem, so you're gonna aspirate. I'm not talking about like once in a while, but it's continuous sort of an aspiration type thing. So if you're going into alcohol overuse, you can aspirate. In epilepsy, you're aspirating. Or if you have bronchial obstruction, like in cancer, you can aspirate. Now, air fluid levels will be seen. Picture A, often seen on chest X-ray. And what is the air fluid level? So let's zoom in this one here. So if you look here, I don't know if you can see it or not, but you have a line. And below, lung is supposed to be, if you look here, let me actually do this. Look here. and then the lung is right there. So let me erase this so you can see. So what is all of this, right? So you have an air fluid level, and that's basically, if you look at it, it's going to be a air. If you, I mean, let me just do this. You will see what I'm saying. And you look at this right here. So you see there's a line that is drawn, but you can also see a shadow right there. So that's an air fluid level. Okay, but you can look at it more in Google Images and see how this is, because this is very important. Okay, air fluid level will be seen, okay, on the chest X-ray. Presence suggests cavitation. So when you have air fluid levels, the presence would suggest the cavitation due to anaerobes. Again, we talked about these anaerobes, cause bacteroides, fusobacterium, peptostreptococcus. These are all oropharyngeal organisms which are supposed to be in the mouth, but in the mouth they're normal flora. But as soon as they go down the trachea and go to the lungs, I mean, they're going to start an abscess. They will start the aspiration pneumonia eventually causing abscess. They're normal flora for the oropharynx, though. Or Staph aureus is the other organism. Treatment is antibiotic, simple, drainage, or surgery. Lung abscess secondary to aspiration is most often found in the right lung. Everything is about right lung when you're looking at aspirate, right? Location depends upon patient position. During aspiration, a lower lobe if upright, right upper or middle lobe if recumbent. And we already know that. Okay, so this was pretty easy topic, nothing much. Lung abscess, are you going to look at, there's going to be abscess formation with the air fluid levels high yield because of cavitation, and the organism could be anaerobes or Staph aureus. Treat antibiotic, drainage, surgery. And this is the etiology why the abscess occurred. I mean, why did the person aspirate? Right? And depending on the position, you're going to have the right lung placement of those things, but depending on the patient's position. Okay, moving on to the next one is lung cancers, high yield. High yield, okay, these cancers are pretty high yield. So what do we have here? Okay, so lung cancers, they are the leading cause of cancer death. Leading cause of cancer death. Presentation is cough, hemoptysis, bronchial obstruction, wheezing, pneumonic coin lesion on chest X-ray, or non-calcified nodule on connective tissue. Sites of metastasis from lung cancer are liver, jaundice, hepatosplenomegaly, adrenals, bone pathological fractures, brain, lung mets. So the mnemonic here is love, affective, bonehead, and brainiacs. So love, affective, boneheads, and brainiacs. So liver, adrenal, bone, and brain. In the lung, you have metastasis. Usually multiple lesions are more common than the primary neoplasms. Most often from breast, the colon, the prostate, and the bladder cancer. So in other words, in the lung, mets are more common than the actual cancer arising from the lung itself. Severe of the complications are superior vena cava syndrome. You have thoracic outlet syndrome, pan-cause tumors, Horner syndrome, endocrine or the paraneoplastic, recurrent laryngeal nerve complication, and hoarseness. Effusion is pleural effusion or pericardial effusion. So the mnemonic is here severe. So this is sort of a important way to go. Superior vena cava, pan-cause, Horner, endocrine, paraneoplastic, high yield, recurrent laryngeal nerve compression, hoarseness, and effusion. Risk factors for the lung cancers are tobacco smoking, secondhand smoke, radiation, environmental exposures like radon, asbestos, pulmonary fibrosis, family history. Squamous and small cells are central. That's very high yield. That squamous and small cell are going to be central and often caused by tobacco smoking. Hematomas are found incidentally on imaging, appearing as well circumscribed mass. Okay, so let's look at individually one of them. So here what we have is the small cell oat cell carcinoma. So small cell oat cell carcinomas are central. We talked about two S's being central, so just get those out of the way, in which we have small cell and squamous. So all the S's are central, and the rest is just peripheral. Okay, so just S's are central. So let's look at the first one we're talking about, small cell. Small cell oat cell carcinoma, they're going to be central. They're undifferentiated and they're very aggressive. So because they're small cell, they're very aggressive, may cause neurological paraneoplastic syndromes, high yield. What paraneoplastic syndromes can occur is the Lambert-Eaton myasthenia syndrome, paraneoplastic myelitis, encephalitis, subacute cerebellar degeneration, and endocrine paraneoplastic syndromes like Cushing syndrome, FIADH. And why this occur? What is the pathology behind it? There's an amplification of MEK oncogene managed by chemo and radiation. So these are ones, the treatment is chemo but no surgery. No surgery. What is the histology? Histology, we will see neoplasms of neuroendocrine colchicity cells, which are small dark blue cells, picture A. Small blue cells. You can see it in picture A, all of that, right? And this is chromogranin A positive, non-specific enolase positive, and synaptophysin positive. All of that positive because these are neuroendocrine cells. Neuroendocrine cells will have these neuroendocrine markers. So one is chromogranin A positive, neuron-specific enolase positive, synaptophysin positive, and the other thing that you will see is NCAM positive. NCAM positive. What is NCAM? Is the neural cell adhesion molecule, also known as CD56 positive, within these neuroendocrine tumor markers. Okay. Okay. What else we can have? So because it is a central, now if you think about it, it's gonna cause a mediastinal mass. Right. That mediastinal mass can cause the obstruction of the mediastinal structures. On top of that, it can cause tracheal deviation. Tracheal deviation. Okay, and smoking is a risk factor for this, and it's going to occur more in males greater than females. And it is very aggressive, sort of a tumor. And then you have the next one is all about your non-small cell. So the non-small cells are a couple in which we have adenocarcinoma, squamous cell, large cell, and bronchial carcinoid tumor. So in the adenocarcinoma, it is peripheral, and it is most common primary lung cancer, most common subtype in people who do not smoke, more common in females and males. There is an activating mutation in the KRAS, EGFR, and ALK associated with the hypertrophic osteoarthropathy, which is clubbing. Bronchoalveolar subtypes of adenocarcinoma in situ on chest X-ray will show hazy infiltrate, similar to the pneumonia, with the better prognosis. You will see glandular pattern, often stain mucin positive. Bronchoalveolar subtypes. So there is a subtype, bronchoalveolar subtype. So this subtype will go along alveolar septa, causing apparent thickening of the alveolar walls. Tall columnar cells containing mucus. Okay, so some UL points are, although we're saying non-smoking, but smoke would increase if somebody is smoking. It would increase the risk of cancer, lung cancers, and non-smoking most commonly have the adenocarcinoma. So as for the treatment, you can have surgery here in the early stages. Okay, because it is a peripheral one, it can cause pleural effusion. Because it is at the periphery, so it goes out into pleura, causes pleural effusion. Okay, and some other things other than clubbing, which are associated with this, are dermatomyositis or polymyositis, and migratory thrombophlebitis can also occur. Okay, yeah. So that's what we have. For adenocarcinoma. Then we have squamous cell carcinoma, S for central hilar mass, picture C, and you can see it here. You have a hilar mass arising from the bronchus cavitation. Cigarette hypercalcemia produces PTHRP, which is PTH-related peptide. So this is keratin problem. Because it is squamous, squamous is always keratin. Squamous is the skin with the keratin. Squamous cells, right? They have the keratin. So keratin poles will be seen. Picture D. You can see keratin poles with intracellular bridges. Important. If I zoom in, you'll be able to see those intracellular bridges. There is a better picture somewhere else I saw, but not here. But there are intracellular bridges. Okay, but keratin poles, intracellular bridges, desmosomes are there. Now, the most important thing is this thing right here, the hypercalcemia here. So, hypercalcemia, because of increase in PTH here, would cause hypercalcemia. Yeah, simple. And if you recall, the PTH doesn't directly you have hypercalcemia with the increase in PTH-related peptide and PTH-related peptides. So these cells are going to secrete that paraneoplastic. These paraneoplastic cells will secrete the PTH-RP, and then that would cause hypercalcemia. To treat that, that's also a yield point. How do you treat this thing? Well, to treat this, you have bisphosphonates. Now, if you could recall, bisphosphonate, we don't take bisphosphonate as the thing to treat hypercalcemia. But why are we doing it here then? Because bisphosphonate is going to inhibit the osteoclasts. And if you recall, PTH indirectly works on osteoclast to activate osteoblast and everything. And when you stimulate the osteoblast, you're trying to get out that calcium out. So if you inhibit this cell, even if you have high PTH, nothing is going to go. There's going to be no effect on the bone. So that's why you're giving bisphosphonate, which will directly inhibit this. And this is a very high yield point. Treatment for hypercalcemia in squamous cell cancer is bisphosphonate, which would inhibit the osteoclasts. Okay, then we have this large cell carcinoma, which is in the periphery, highly anaplastic, undifferentiated tumor, strong associated with tobacco smoking, may produce HCG, causing gynecomastia, which are enlarged breasts, less responsive to chemotherapy removed surgically, poor prognosis. Pleomorphic giant cell will be seen in picture E, and if you look at picture E, you will see pleomorphic giant cells, so macrophages, pleomorphic macrophages, giant cells. My bad, not macrophages, but these large cells are seen as giant cells, okay? And you can see them as I highlighted over there in picture E. But you have the next one is the bronchial carcinoid. Carcinoid could be anything, central or peripheral. Excellent prognosis, metastatic rare. Symptoms due to mass effect, wheezing, or carcinoid syndrome, which is flushing, diarrhea. And this is nets of again, same thing, neuroendocrine cells. So you're going to have a chromogranin A positive. Chromogranin A positive. With this one, let's add some more with the beta HCG. So you're not going to have gynecomastia, but also on top of that, you can have galactorrhea, gynecomastia, and you have no glands. So you only see these giant cells. There are no glands, or mucin or keratin poles, Okay, and now let's just quickly revise this and move on to the next one. Okay, let's look at this. So we talked about how presentation wise you can have this coin lesion on the chest x-ray, hemoptysis, or the nodule on the CT. Metastasis is common from the lung cancer as a secondary thing, meaning in the lung the metastasis is more common than the primary cancers of the lung. And so lab could be the mnemonic LABB or B2, in which case you have a liver, adrenal, bone, and brain. Lab are the common metastasis, site of metastasis from the lung cancer. Okay, the complications are severe of complications. So severe SVC, Pancoast, Horner, endocrine, paraneoplastic high yield, and recurrent laryngeal nerve compression and effusion. Risk factors: tobacco smoking, pulmonary fibrosis, family history. Important SS for central and smoking. They're all central and all caused by smoking. And then you have, let's look at each one of them quickly. Small cell, very aggressive. There's this very aggressive tumor, and it is neuroendocrine positive. Chromogranin A, neuron-specific enolase and synaptophysin positive with CD56 positive, and CD56 is the NCAM positive. Non-small cell ones are four, in which the first one is adenocarcinoma. It does not start with S, so it is going to be in periphery. It is most common due to non-smoke mutation. The KRAS EGFR ALK causes clubbing. There's one type which can show hazy infiltrate to pneumonia. So it is going to look like a lobar pneumonia, or pneumonia like of consolidation, right? It has a glandular pattern because it's an adenocarcinoma with the gland. So mucin positive. You see mucin positive adenocarcinoma. Apparent thickening of the alveolar walls and tall columnar cell will be seen. Squamous S central. With the S you have hilar mass. With the other S we talked about just the central mass, causing mediastinal, basically mass. And here we are looking at hilar mass. So we were talking about this two small cells. So one is central, the other one is also central, but one is going to give you mediastinal mass, and one is going to give you hilar mass. Okay, and that's all for that one. So this squamous one is going to give you PTHRP high yield with the hypercalcemia. So CCC, so squamous hypercalcemia, cavitation, cigarette smoking with the C keratin poles. Call it C keratin poles. Keratin poles in intracellular bridges. With a large one, you are looking at, with a large cell carcinoma, you are looking at it as a highly anaplastic undifferentiated tumor, right? And it can produce beta ICG. So these, what they produce in extra, that's very high yield, and that is specific to those. So got to know that, right? So if you look at beta ICG is high, you're gonna think about large cell carcinoma, which can cause gynecomastia, galactorrhea, and you have to remove it surgically. Poor prognosis. With the giant cells, pleomorphic giant cells, are going to be seen in the histopath. For the bronchial carcinoid one, you have it as an excellent prognosis, but you can have some mass effect due to it because it's a big tumor, or you can also have a carcinoid syndrome like features refreshing diarrhea with the neuroendocrine tumor positive, tumor marker positive, which are chromogranin A positive. Moving on with the Pancoast tumor, also known as superior sulcus tumor, carcinoma that occur in the apex of the lung may cause Pancoast tumor by invading compression of the local structures. So what is Pancoast tumor? Well, it is simply something with the apex of the lung which causes the compression of local structure. It'll be known as Pancoast tumor. Okay, now the compression of what structures are we looking at? The structures we are talking about are the compression of local regional structure may cause area findings. For example, recurrent laryngeal nerve causes hoarseness, stellate and ganglion causes Horner syndrome, which is ipsilateral ptosis, meiosis, and anhidrosis. High yield. Superior vena cava syndrome can block the superior vena cava and cause the full syndrome, and we'll read that in the next one. Then you have the brachiocephalic vein. So when you block the brachiocephalic vein, it's called brachiocephalic vein syndrome or brachiocephalic syndrome, unilateral symptoms. Okay, now brachial plexus, if you block it, you know you already have shoulder pain, sensory motor deficits, atrophy of the intrinsic muscles of the hand, phrenic nerve damages called hemidiaphragmic paralysis. Hemidiaphragm elevation on the x-ray. Now high yield point here is there's an ipsilateral hemidiaphragm elevation, meaning whichever side you damage, that damaged side will be elevated in this hemidiaphragm elevation on the chest x-ray. So simple, again, Pancoast tumor, any sort of a mass which is in the lung, most likely the cancer itself, which would invade the compression of the local structures, and these are all the local structures, and you can call that Pancoast tumor. Looking at this picture, look at the mass. That mass is just hitting on the first rib and trying to have the compression of your apex of the lungs, right? And this is all for the Pancoast tumor. Moving on with the next, which is called superior vena cava syndrome. This is the obstruction of superior vena cava, okay, and which is due to thrombus, tumor, impairs the blood drainage. Drainage is impaired from the head. So you have superior vena cava, you block this thing right here, nothing from top is gonna come down. So you will have the blood drainage from the head, impairs the blood drainage from the head, which give you blockade. So you will have facial plethora. If you see in this patient, facial plethora is seen, which is in other words known as red, because of that blood just being there. It's going to give you redness, facial plethora. not blanching after fingerprint pressure in picture A. My bad. Note, not blanching. Note blanching, meaning you can see the blanch. If you press on it, you will see that the blood is going to deviate here or there. So it's called blanching when you put the pressure on it. On the neck, jugular venous distension is going to be seen, and your laryngeal pharyngeal edema will be seen, and upper extremity edema is also seen. So again, you have a head, everything. So because nothing is coming from top, from superior vena cava, so the blood is just gonna be all over the face, the head, and also the upper extremities edema will also be seen, because the blood is gonna push on the sides as well, because it's not going into the place where it has to go, which is superior vena cava to heart and then to the circulation back. So commonly caused by malignancy. Which malignancy are we looking at? Anything that blocks, let me erase this, so anything that would block the superior vena cava, which is your mediastinal mass Pancoast tumors, thrombosis from the indwelling catheter. So when you develop a central line, you can cause thrombosis, and that thrombosis could be one of the risk factors causing superior vena cava syndrome. It's a medical emergency and it can raise intracranial pressures if obstruction is severe. And when you increase the ICP, you're going to cause headache, dizziness, and increased risk of aneurysms or rupture of the intracranial arteries can also be seen. Looking at this picture, we have obstruction in the superior vena cava. Right there is the obstruction of the thrombus. So everything is just blocked up. All the pressure goes back, and the fluid just goes in the extremities. And also JVD will be seen, and also facial plethora with the blanching of after the fingertip pressure will be seen. So that's all about superior vena cava. Let's move on to the next one. Actually, it's all done. Great. Let's talk about pharmacology now. Pharmacology, easy. Okay, what are we looking at? H1 blockers. H1 blockers. So H1 blockers are the one also called antihistamines. They're reversible inhibitors of H1 histamine receptor. Reversible inhibitors may function as a neutral antagonist or inverse agonists. Okay, that's important. And what are the drugs? We have the first generation and the second generation. The first generations are diphenhydramine, dimenhydrinate, chlorpheniramine, and doxylamine. They named usually contain N9N8. Okay. Clinical uses of this H1 blockers are your allergies, motion sickness, vomiting in pregnancy, high yield, sleeping aid. Okay, as they're just blocking the H1, they are used here, and the important thing is that because the first generation, or the way I think about it, the first generation are the first thing they make, right? So they don't make it perfect. So they cross blood-brain barrier. So when they cross the blood-brain barrier, it causes sedation. So first generation are like old sort of a generation, let's say, and they cause sedation. But the second generation, there is a decreased CNS entry, so it's less sedating. Because it is decreased CNS entry to CNS, and those second generations are loratadine, fexofenadine, disloratadine, and cetirizine. Usually, what do we have is the name end in adine, and cetirizine is second generation agent, high yield. And one more important thing is they're selective. They're very selective for their H1 blocking effect. While the first generation they are sort of a so they're non-specific and interact with multiple receptors. That's important. They affect with multiple receptors, including the muscarinic receptor. And that would give you anti-cholinergic effects, because you're blocking the acetylcholine receptor, which is also known as muscarinic receptor. You're going to get the anti-cholinergic effects. right? So because this is old generation, the old is like first prototype, let's say. So they cross BBB, they're non-specific. So they were like, hey, you gotta make something new now, something more specific for the H1. So they made selective H1 blocking agents, which would not cross CNS, which would not cause sedation, which will be specifically used in allergy. Okay, so this is all about H1 blockers. Looking at the next one is dextromethorphan. It is antitussive. It antagonizes NMDA glutamate receptors. Synthetic coding analog has mild opioid effect when used in access. Naloxone, which is an opioid antagonist, can be given for this overdose. Why? Because this dextromethorphan is an opioid, is a mild sort of an opioid, right? So you can give the same drug which you give for opioid as an overdose. So naloxone can be given. Mild abuse is potential. May cause serotonin syndrome, high yield, if combined with serotonergic agents. But what is dextromethorphan? Dextromethorphan antitussive antagonizes NMDA glutamate receptors. Antagonizes NMDA glutamate receptors, right? And it is a codeine analog, by the way. Okay, then we have the next thing. What do we have? It's the pseudoephedrine and phenylephrine. Pseudoephedrine, phenylephrine. Activation mechanism is the activation of alpha adrenergic receptors in the nasal mucosa, causes local vasoconstriction. The clinical use is reduces hyperemia, edema, used as nasal decongestant, open the obstructive eustachian tubes. Adverse effects are hypertension, rebound congestion, rhinitis medicamentosa, high yield. So it can cause hypertension and also adverse effect rebound congestion, which is rhinitis medicamentosa. What is that? That is, if you use these drugs for more than 4 to 6 days, you will have rebound congestion. What is rebound congestion again? That you will again have this runny nose and hyperemia with everything. And why did that happen? Well, because you use these drugs, they're going to block these alpha receptors. So when you are giving them for 4 to 5 days, they have blocked all the alpha receptors. And no matter how much drug you're giving, because of desensitization, the receptors are not present there. They have desensitized because you have persistently, you are just activating these alpha receptors. So they will desensitize, meaning there will be no receptors on the surface. You give the drug is just going to linger on over there. There's no receptor to work on. And you will have rebound congestion, rhinitis medicamentosa. Okay, again, the name says right there, rhinitis, runny nose, medicamentosa, due to some medical thing. Which medical thing? You're giving the drug more. Okay, and then associated with tachyphylaxis, same thing, can also cause CNS stimulation and also anxiety. The next one is high yield. It's called pulmonary hypertensive drugs or hypertension drugs. So we have first drug is endothelin receptor antagonist. If you recall, let's actually recall right here. What was endothelin doing? Well, endothelin was causing the vasoconstriction. When you cause vasoconstriction and increase the proliferation, eventually you're causing pulmonary hypertension. So we got to stop this, right? How do we stop it? We give endothelin receptor antagonist right here. And what is that? Well, that is going to be your boss and tan. Okay. And for endothelin. Okay, so competitive antagonist of endothelin 1 receptor causes decrease in pulmonary vascular resistance, basically indirectly decreasing the pulmonary, actually directly decreasing the pulmonary vasoconstriction and decreasing pulmonary hypertension. But it is hepatotoxic. You got to monitor LFTs, example bosentan. Now the next thing, looking at this one, what do we have? We have the prostaglandins, right? Looking at this, looking at how nitric oxide Actually, let's talk about nitric oxide. So we have a nitric oxide. Nitric oxide comes and causes vasodilation, but it is destroyed by the PDE5 inhibitor. I mean PDE5. So let's look here. Actually, let's get back. So PDE5 inhibitors, right? So they would inhibit the PDE5, which is normally trying to destroy that GTP, causes increase in cyclic GMP, and GMP gets destroyed by your PDE5. So if you try to inhibit this, you will have more of this increase in cyclic GMP. So when you have more of cyclic GMP, this will lead to more vasodilation, right? And it's just going to prolong. So PDE5 inhibitors will prolong the effect of nitric oxides, right? And also used to treat erectile dysfunction. It is contraindicated when taking nitroglycerin or other nitrates due to risk of severe hypotension. Okay, example is sildenafil. Now the prostacyclins, what do we have? Prostacyclins analog, PGI2 prostacyclins with direct vasodilatory effect on the pulmonary and systemic arterial vascular beds. They would inhibit the platelet aggregation. Adverse effects are flushing, jaw pain. Examples are epoprostenol and iloprost. Okay, let's look at it in the picture. Prostacyclins, they're going to cause increase in cyclic GMP, cyclic AMP, and that will lead to, again, vasodilation and decrease in proliferation, right? And if you give something from outside, which increases the cyclic AMP, which is these two drugs, epoprostol and iloprost, they would lead to vasodilation, increase in proliferation. And that's all for these pulmonary hypertensive drugs. Okay, moving on with the asthma drugs. What do we have here? So bronchoconstriction is mediated by inflammatory process and apparent parasympathetic tone. Therapy is directed at these two pathways. Again, what are we talking about? We're talking about in asthma. We have bronchoconstriction, right? That is mediated by either the inflammatory process, because of inflammation we're getting bronchoconstriction, or it is the parasympathetic tone is increased, so that we are getting bronchoconstriction. So therapy is about these two pathways. Let's look at the inhaled beta-2 agonists. Inhaled beta-2 agonists are albuterol, salmeterol, formoterol. They relax the brachial smooth muscle, can cause tremor and arrhythmias. Right? Albuterol is short-acting and used for acute symptoms, and salmeterol and formoterol are long-acting. Important. Albuterol is short-acting, and these two are long-acting. That's the inhale. What are they doing? Inhaled beta-2 agonists, they're just relaxing the bronchial smooth muscle. And remember, the whole problem in the asthma is bronchoconstriction. So we're trying to relieve that episodic, intermittent, paroxysmal bronchoconstriction by giving these inhaled beta-2 agonists. But if we give a short-acting, it's only going to act for, like, let's say 2 hours, while the long-acting, which is going to act, actually, let's talk about that. So what are the short-acting, how long they act? Well, they're going to act for 4 to 6 hours, and the long-acting will act for more than 12 hours, right? So that's with the inhaled beta-2 agonists. Moving on with the inhaled glucocorticoids, which are fluticasone and budesonide. They inhibit the synthesis of virtually all cytokines. So basically, they inhibit all cytokines. They would inactivate NF-kappa B, the transcription factor that induces the production of TNF-alpha and other inflammatory agents. They are the first-line therapy for chronic asthma. Use a spacer or rinse mouth after use to prevent oral thrush. Right? And how the oral thrush is going to present with, so it's a person who's taking the specifically they'll say a child who comes in, he doesn't use a spacer, and now he has an oral thrush. They won't say oral thrush. What they're gonna say is white plaques that can scrape off, that can easily be scraped off. So white plaques on the tongue that can easily be scraped off. It is oropharyngeal candidiasis, oral thrush, in other words, right? And and you have to tell them, okay, rinse your mouth after the taking the steroid, and also you could use spacer for it. If you don't rinse mouth, you can use spacer. But the other complication that they can present is dysphonia. Dysphonia. And what is dysphonia? It is due to the myopathy of the laryngeal muscles. Okay, so dysphonia can happen in these patients. So what are they doing? Glucocorticoids, you're just trying to inhibit all inflammatory things. Anything with inflammation, cytokines, TNF-alpha, anything, they will inhibit that. Used in chronic asthma. Moving on with the muscarinic antagonism. Remember, the tone was high, so we want to block this out. So to block it out, we have muscarinic antagonism, which is tiotropium, ipratropium. They're competitively, they will block the muscarinic receptors, preventing bronchoconstriction. Also uses COPD. Tiotropium is long-acting, right? Okay, then we have the next one is and this was simple, right? Just note the drugs: tiotropium, ipratropium, muscarinic antagonist. The next is anti-leukotrienes or leukotrienes, which are monteleucost, zafirleucost. They would block the leukotriene receptor cis-LT1. Especially good for aspirin-induced and exercise-induced asthma, while xylitol is a 5-lipoxygenase inhibitor. It would decrease the conversion of arachidonic acid to leukotrienes, which is hepatotoxic. So let's look at these in this picture. Anti-leukotrienes. Here is the anti-leukotrienes, monteleucast, zafirleucost, and xylitol. So if you look how, so you have pro-inflammatory cytokines, which are gonna give you arachidonic acid metabolites, leukotrienes, and the prostacyclins, the glandins, and thromboxane. So we did inhibit the phospholipase A2 and COX1 and 2 via glucocorticoids, which are fluticasone budesonide. But we have to inhibit the other pathway of the arachidonic acid, which is 5-lipoxygenase pathway. So inhibit that, which is eventually going to form leukotrienes, right? So inhibit that 5-lipoxygenase pathway. We are going to give xylitol, one thing, or we can give the inhibition of that receptor which the leukotrienes work on. So they work on CYSLT1, cis-LT1 receptor. So we can give receptor blockers, which are anti-leukotrienes, monteleucast and zafirleucost, which we can inhibit this receptor. So if you inhibit this, if you block this out, even no matter how many leukotrienes you have, they're not going to work here. So when they don't work here, they won't cause bronchoconstriction. So mucus secretion, plasma exudate, eosinophil recruitment. So you're just trying to block all of that, and also you're trying to block this bronchoconstriction. So that's the mechanism of anti-leukotrienes. Then you have the other ones, which are your anti-IgE monoclonal therapy, which is omalizumab. So MAB is always monoclonal antibodies, right? So omalizumab is IgE monoclonal therapy. They would bind mostly unbound serum IgE and block the binding of Fc epsilon R1. Used in allergic asthma and increase in IgE levels resistant to inhaled glucocorticoids, long-acting beta-2 agonists. So let's look at that in the picture. Omalizumab. Okay, right here is the IgE monoclonal therapy omalizumab. So what is this cell? Well, this cell is a mast cell which is trying to degranulate. So when you're trying to degranulate, these mast cells have the receptor on them, which is IgE receptor. So you can block that IgE receptor. And if you recall, how does the mast cell activate it? Well, the mast cell get activated. Let me just write here. So it has all the mast cells have IgE receptor. And when any antigen binds to this IgE receptor, not one, but when the antigen binds and dimerases these two IgE receptor, this thing leads to activation of mast cell. So when the activation occurs, there's going to be degranulation of the mast cell, which are going to release the pro-inflammatory cytokines, which is mentioned right here. Leukotrienes, histamines, interleukins, they're all released when the mast cell degranulate. Actually, looking up top, you have the allergen. You're exposed to the allergen, example, the pollen, the dust in the asthma. So this binds allergen-specific IgE and dimerases these two things. You see there are two IgE antibodies on the mast cell. So they dimerize. When they dimerize, they activate the mast cell. When they activate the mast cell, that leads to degranulation. So we have to block this Fc receptor for IgE so that no allergen can bind. An allergen is not it's just a dust or pollen, right? So omalizumab can be given, which is going to block these IgE receptors. So no matter how much allergen or pollen outside you have, you will not activate the mast cell, right? And that's the mechanism of action of omalizumab. So let's read it from there as well one more time. It binds unbound IgE, serum IgE, and block the binding of Fc portion of the R1 used in the allergic asthma specifically, with increased IgE level resistant to inhaled glucocorticoid, long-acting beta-2 agonist. Okay, and then the next one, let's talk about, so since we are here, let's talk about cromolyn, which is right here. Chromones or cromolyn. Cromolyn prevents the mast cell degranulation, prevents acute asthma symptoms, rarely used. So if you look here, mast cell activates and causes degranulation. You wanna block that degranulation. How do you do that? You give cromolyn. When you give cromolyn, you're blocking the degranulation. When the degranulation is not gonna happen, guess what? You're not gonna get all of this pro-inflammatory mediator release from the mast cell, causing inflammation. So that's the cromolyn. Other than that, if you look here again, glucocorticoids come into the place, which are the glucocorticoids are the inhibition of all inflammatory cells, right? So they are also inhibiting the mast cell itself to not basically to inactivate it, so that you don't lead to all that degranulation or anything. So that's the fluticasone and budesonide. Okay, now let's look at methylxanthines. Methylxanthines, right here. Methylxanthines, they are theophylline. They are likely cause bronchodilation by inhibiting the phosphodiesterase, which causes increase in cyclic AMP levels due to decreased cyclic AMP hydrolysis. Sort of like the one we talked about in the previous page, which was PDG5 inhibitors, right? And they were doing they were trying to inhibit the cyclic GMP, and this is trying to inhibit cyclic AMP. So we block this phosphodiesterase that is degrading cyclic AMP. It is limited use due to narrow therapeutic index, high yield. It has a narrow therapeutic index, can cause cardiotoxicity, neurotoxicity. It is metabolized by P450, high yield, and it blocks the action of adenosine. So let's look at in the picture where the methylxanthines are, right here. Methylxanthines, which is a theophylline, this drug is going to, if you look here, let's look at here, okay. So we have cyclic AMP, Cyclic AMP is causing the bronchial tone to go into dilation. That's what we need. But cyclic AMP gets destroyed by this phosphodiesterase. And that PDE5 in the other one will also phosphodiesterase 5 inhibitor 5. And this is phosphodiesterase. So phosphodiesterase is so this is degraded by phosphodiesterase. So we would what do? We would inhibit this phosphodiesterase, so we will have more and more of cyclic AMP. When we have more and more cyclic AMP, they will stimulate the bronchial tone to go into bronchial dilation, right? So that is theophylline. That's one thing. The other thing is they will directly block the adenosine and adenosine, which was causing bronchoconstriction directly. So theophylline has two things. So let's look at the phosphodiesterase 4 inhibitors. 4 is the roflumilast. Roflumilast, they inhibit the phosphodiesterase, increases cyclic AMP, causes bronchodilation, used in COPD to reduce exacerbation. Same thing. Roflumilast, COPD only, it would also inhibit this PDE, which is phosphodiesterase, and you will have increase in cyclic AMP and bronchodilation will occur. We talked about chromones, and now the last one is the anti-interleukin 5 monoclonal therapy. In anti-interleukin 5 monoclonal therapy, it prevents eosinophil differentiation, maturation, activation, survival mediated by IL-5 stimulation for maintenance therapy in severe eosinophilic asthma. The drugs are mepolizumab, reslizumab against IL-5 specifically, and benralizumab against IL-5 receptor alpha specifically. So let's look at these in the picture right here. So we have T helper 2 cells which are going to release IL-5, and that IL-5 will go and stimulate this receptor, IL-5 receptors, on eosinophils, right? And once eosinophil is activated, again it's going to release the pro-inflammatory cytokines, which is causing acute inflammation and eventually chronic inflammation, or acute response and chronic response. So we have two sort of drugs. We can give IL-5 inhibitors, which are mepolizumab and reslizumab, or we can give IL-5 receptor inhibitors, which is benralizumab. So that's pretty much what we have for these asthma drugs. But the thing is, one more important thing for these drugs are they're not just given as, okay, try this, try that. So they're given as a stepwise fashion, meaning, let's go through the stepwise fashion quickly. Okay, the way they're given is, you first of all, if somebody comes with asthma, so you give the beta-2 agonist, inhaled beta-2 agonist. That's a step 1, and it is called SABA, short-acting beta-2 agonist, which is albuterol. If that doesn't fix the problem, you move on with the second step, which is inhaled glucocorticoids, ICS. If this doesn't fix the problem, then you move on with the LABA, which is right here. LABA. What is LABA? Long-acting beta agonists. If that doesn't fix the problem, then you add the tiotropium, which is right here. If this doesn't do it, then you would add this anti-IgE monoclonal antibody, omalizumab, and the rest of these are just specific to the actual problem. But if that doesn't even fix the problem, then you go with the last resort, which is oral steroids, corticosteroids. but mostly patients do fix with the other ones because there's a lot of adverse effects with this oral corticosteroids, which is like prednisone. So a lot of adverse effect with it. So most people do get fixed by the top 5 approaches, and that's all for respiratory